function, very highly sensitive for some nerves. It can assess nerve conduction, it can assess conduction block, and of course, it can assess axonal loss. And it can also differentiate between neuropraxia and axonotmesis. Well, the ultrasound can do that as well, actually, as we will learn it later on. Can assess relative chronicity, whether the problem is already chronic or it's acute, and can also assess more generalized peripheral neuropathy. So these are very important strengths that we need to also know about EMG. The weakness is that it is user dependent, much like what we have in ultrasound. The techniques and values are often not standardized, requires understanding of temporal changes. So there's a lot of other factors that could affect that, like temperature, the weight of the patient. Those information could alter some findings that we normally see in EMG. It does not provide anatomic correlation, which is often the source of neuropathy. So let us keep in mind that even though this is a very useful modality for diagnosis, there are some limitations that we need to know, and we cannot just overread it. It cannot distinguish also between a complete axonotmesis from neurotmesis. So these are the weaknesses of EMG. For ultrasound, of course, the strength of ultrasound is that it provides anatomic correlation in peripheral neuropathy. So whatever we see would eventually be converted into some anatomic change. So we need to see exactly what those changes are in order to interpret it very well and to also assess it. And it can also assess vascular flow. So these are by means of your Doppler, your power Doppler, or your color Doppler. And very important and very distinct about it, ultrasound is that it has an ability for dynamic assessment. So this is really very important. And then, of course, other advantages is that it's relatively inexpensive. It has better soft tissue differentiation than MRI, better spatial resolution, can provide focused evaluation. So if we know exactly where the problem is, then we can actually see changes, anatomic changes that can explain why patients are suffering what they're suffering. It is also a dynamic assessment, as we have mentioned earlier. It also allows easy side-to-side comparison. So if we are not sure about our findings on the affected side, then it is always important to compare with the normal side, hoping that the other side is normal, unless otherwise it's both affected. No issue to claustrophobia, as we experienced that in MRI. So you can always do it anywhere. It's portable. No interference with implants and pacemakers. So it's very, very safe. Well, the weakness of MSK ultrasound is that it's user dependent. It is not standardized. It's a newer technology. There is very little physiologic assessment, if any. And it also generally less than electrodiagnosis to assess relative severity. So if you compare EMG and ultrasound, it has lesser ability to assess that. Does not really identify a more generalized process and more difficult to evaluate large fields. So if there is a very big area of involvement of that specific site, then it will be very difficult to use just an ultrasound. Does not penetrate bone. So if the lesion is beyond the bone area, we wouldn't be able to diagnose it because it cannot penetrate beyond that bone. And of course, there is an attenuation with tissue thickness. So if the tissue that we're looking at is very deep or very thick, then we might not be able to really appreciate the entire lesion that we're looking at. And so those are the weaknesses of using MSK ultrasound. So these are the patterns that we see in EMG. So these are just diagrammatic. So we would understand exactly how they look like. This is a complete neuropraxia, for example. There's no reading, there's no signal. beyond a point of a lesion, or it could be an incomplete neuropraxia. There's a conduction block somewhere because of the impingement of a nerve, for example, or there is axonostenosis. In other words, there is narrowing of the axons. That's why it could not transmit the impulses beyond the area. Or there could be, as what happens sometimes with elder patients, axonocatexia. The nerve has really chronically went into a degenerative process. And so we need to also realize this one. Okay, the principles of this practice is that we were able, especially with ultrasound, to identify the nerve tissue. So we should be able to see what exactly how the nerve tissue looks like using good technique. Of course, in good technique, it includes ergonomic. You have to know the surrounding anatomy, what are the structures involved. There is consistent measurement techniques. It's not always ideal, of course, to be measuring a lot of normal values or basing it with normal values, because sometimes it may vary. There's no specific agreement as to the measurement that is available, but whatever it is, it's always ideal to compare it with the right and the left. And we should also assess in both short and long axis. So there is always ideal way of doing it. So try to see the nerves in short axis and compared with the long axis, how do they look like? And of course, very important is we have to follow the course of the peripheral nerve. So even as we say that the window of visibility of ultrasound is very narrow, if we know exactly where the nerves is passing through, how it goes into that area, then we would be able to see if there's any changes that is happening with the peripheral nerve. Okay, so for MSK ultrasound setting, we can either use, of course, a curvilinear or a linear, but since a lot of these structures may be seen superficially or not so deep, unless we are dealing with nerves in the buttocks or in areas which are very thick, then we would just use a linear high resolution transducers. And of course, depending also on the anatomy and the build of the patient, we will have to adjust which type of transducers are we using. So at least 12 to 5 megahertz. And of course, for the fingers, 17 to 5. There's some probes where you can actually go up to about 22 up to 5, which is really very good. And of course, for deep structures like the hip, it's 5 to 9 megahertz. So depending on what structures are we looking at, then we can always adapt to or change the kind of probe that we're using. So when we look at peripheral nerves, of course, we always characterize this nerve as a honeycomb pattern. So you look at the honeycomb, okay? So that is exactly how the nerves look like. And we need to also identify not only just the nerve, but of course, the characterization of the nerve, the caliber of the nerve. Is it big or is it small? And then, as I mentioned earlier, there could be some values that were found in studies, but there's always a lot of debate about whether this is acceptable or not. So we cannot use them all the time, although that's also very helpful. Then of course, nerve echotexture. Is there a very distinct fascicles that you see? Is depending also on the ultrasound that you're using. If you're using a very basic kind of ultrasound, you might be able to appreciate the echotexture very well. So, but if you have a very good high, ultra high, maybe ultrasound, you can see all the details. You can even count the fascicles inside. Okay, and then of course you have to identify if there's any enlargement or if there is any impingement. So you can see that in ultrasound. If there's any masses, this is very interesting because while we agree that the nerve is superficial to a greater extent, now we should not magnify the nerve too much that we may lose sight of the neighboring structures that might actually be the one that may be causing the problem. So this is very important as we go along our study on nerves. And of course, the presence of fluid around the nerve or even near to the nerve, which could be coming from the tendons or other soft tissue structures around that area. So these are the characteristics that we need to see. Then of course, in both short and long axis, then we can characterize how a nerve and a tendon looks like. Now, if you will try to see, it's sometimes very difficult in the beginning to distinguish what a tendon and a nerve looks like. But usually a tendon are usually echogenic. They're usually more white. And the nerve are usually trilaminar. In other words, there is a distinct echogenicity on the peripheral area in long axis. That's what you see on the image on the left. And then of course, darker on the middle. But of course, there are other connective tissue in between. So you really look at it like a tram track. It's almost like the railroad track. So that's how the nerve looks like in long axis. But of course, in short axis, sometimes you mistook this for tendons. But the best way to do it is to toggle your probe or do heel toe and see whether there's a lot of change. Usually, if you're seeing nerves, there's not much change. It's not affected too much with anisotropy. So if you look at the nerve tissue, you don't see any or a lot of changes really. But if you look at the tendon, when they are perpendicular to the probe, they almost look very echogenic. But if they are not, then they become anisotropic. So it becomes black. So those are clues that can guide you as you scan the nerve. Okay, and then of course, these are the normal patterns that you see. So just a review. So we have the epineurium, which is the outermost layer of the nerve, and inside the layer we have the perineurium, which is made of the fascicles actually, and there are smaller fascicles inside, which is made of the neurium. So they really look like a honeycomb. So there is a hyperechoic background because of the interfascicular epineurium and the hypoechoic structures that corresponds to the fascicle. So this area is really very important to know because as we look at the structures, they may almost look the same and very hard for us to distinguish. So another characterization is this. So the nerve, if you look at this, is as a honeycomb pattern, okay? Very distinct, while a tendon is echogenic. Look at the difference. It's very white, while the nerve, there are black areas with white dots in between. And of course, I should look at also the long axis. It's, as I've said, it's almost like a tram track, a railroad track. So you can see the echogenicity at the peripheral area, but in the middle portion, it's a little black, although it's still to some extent echogenic, depending on the amount of connective tissue that is present there. But as you compare with the tendons are more echogenic than the nerve. So here, you can also look at these nerves and try to do dynamic movement. So you can see the tendons moving right below the nerve. And so this is the typical appearance of the nerve. It's usually doesn't change with positioning. So that is why it is very easy to distinguish whether you're looking at nerves versus if you're looking at just tendons. Now, how does an abnormal nerve look like? So usually, this is a very good representation here. This is by Professor John Marshall and Sir Victor Horsley in 1883. He identified the nerve abnormality by saying that there is an area which is constricted, so that area is just where the stretched part, and then the one that is inflamed is the one that is characterized by a swelling. There is a hypoechoic swelling. The nerve begins to become bigger. Excuse me. So there is a swelling, proximal to the entrapment site. So if you know exactly where the entrapment site, then you can see a swelling proximal to that. And it is characterized in ultrasound as the notching at the level of compression. Or sometimes you don't see this mechanical notching or impingement, but if you look at the fascicles tends to fuse. And so there is loss of fascicular architecture. What used to be a distinct fascicle tends to become more diffuse, and one fascicle is actually bigger than the other. So you can have a clue that even if the entire nerve circumference or even the diameter of the nerve seems to be normal in appearance, but if you look at the fascicle and the fascicle seems to be bigger, one of them is bigger than the rest, they are not uniformly the same in terms of sizes, then you can make a hypothesis that this nerve has a problem. Okay. Sometimes one nerve may not really be bigger than the rest, but they kind of diffuse or bridge together, then that could also be an indication that that particular nerve has a problem as well. So here, there are different patterns that you see that will lead to an abnormal nerve. So if you will notice here in letter A, there is really a swelling, a generalized swelling of the nerve, and one fascicle is bigger than the other. Or in letter B, one fascicle is just bigger than the rest, but the entire size of the nerve, the cross-sectional area, is still the same. But this one is also considered an abnormal. If you look at the normal nerve, which is on the letter C, you will notice that they almost resemble their sizes. Not much change with the size of the fascicles. They're almost close to each other. And then, of course, one other thing that you need to do is you use a power Doppler. When you use a power Doppler, then there are flow signals that may indicate that there are abnormal hypervascular change. If this is present in such nerve, then we can consider this nerve to be abnormal, because normally there should be no internal flow with color Doppler in normal nerves. So that is why it is very important that we understand those features of the ultrasound so that we can actually use them and help us identify if we're dealing with an abnormal nerves or not. Also, there are different types of nerve injuries. So the more basic ones, a temporary swelling of the nerve is characterized as a neuropraxia. Okay, it almost looks like a nerve that you temporarily impinge, and when the nerve is impinged, it begins to swell, but the fascicular pattern would still be the same. Okay, then we also have axonotmesis. In axonotmesis, there is a diffuse swelling. So the swelling is diffuse, so you can always say that the cross-sectional area is big, and then there is loss of fascicular pattern. There is an irregular nerve caliper, and there is a hypoechoic appearance of that nerve. So that is how this nerve would look like in axonotmesis. Now, if we have to see the peripheral nerves, there are changes that might occur early, and that there might be changes that might occur late. So the earliest findings that we usually see is a decrease in the echogenicity of the connective tissue layers of the nerve. So they are globally hypoechoic. So if you see a nerve that is just swollen with a decreased echogenicity compared with the rest, then that means that it's a very early sign of a defect or a problem or a degeneration of the nerve. So you can almost say that the nerve is just starting to have some findings pathologically. Eventually, it could become hypoechoic swelling. There could be a hypoechoic swelling at the proximal part, usually very close to the site of impingement. And then you can also apply some pressure. If you apply some pressure, there could be tenderness by sonopalpation. And then after that, in a chronic cases, you don't only see the nerve itself, but you check the muscle that are innervated by the nerves. And usually, if you look at the muscle that are innervated by that nerve, usually it will show hyperechogenicity with fatty infiltration, or sometimes with muscle atrophy. The size of the muscle becomes smaller, but the more distinct findings that you see is that it becomes more echogenic. So if you compare, let's say, the right and the left, you can see that there is echogenic, just what like you see here in the right upper portion of the slide. There is an increased echogenicity of the muscle. That means that muscle has been denervated. So when the muscle is denervated by the nerve, that means it's been there for a longer period of time, okay? Then of course, there could be a diffuse swelling with fairly preserved fascicular pattern. So the swelling is very remarkable, but if you look at the fascicles, they almost look normal. So still, this is a mild axonotmesis. Or it could be a diffuse swelling with loss of fascicular pattern. So now we are going to a more severe case, and this could be a severe axonotmesis. Sometimes there could be fluid inside the nerve itself. So that is your intraneural fluid in the nerve itself. So if you see that, then that could indicate a severe axonotmesis. And then of course, it could be a severe type. Okay, as you can see, an hourglass appearance would mean that there is really the flow of the substance inside the nerve is not anymore happening at the axon level. Of course, we finish with neuropraxia, axonotmesis. What about neurotmesis? In neurotmesis, it is characterized by an empty bed appearance. You don't see anything. It's like the nerve, both ends of the nerve has retracted and you don't see anything in between. So that is neurotmesis. Okay. Now another distinct characteristic of nerves also is the presence of neuroma. The neuroma is very painful. So we would want to know how a neuroma would look like in the nerve. And so they are usually a well-defined hypoechoic mass, which could be present inside. We call that intraneural neuroma, or it could be an extraneural neuroma, or it could be a terminal neuroma. So there's just a lot of them. But these are painful sites of the nerve that indicates that the nerve has undergone some traumatic defect in the nerve. So here, this is an example of a neurotmesis. And so you can see that both ends of the nerve has already retracted. And what is left is just the covering, the epineural covering of the nerve. So both ends has already retracted. And this is also an example of a neuroma. So if you look at this ultrasound findings, you will notice that that lump that you can feel actually, this is actually a terminal type of a neuroma. You can see it's very swollen. You cannot even see the borders of the nerve because all you see are the nerve tissue that has become bulbous in appearance, and it has also become very painful if you actually apply some pressure on that when you are scanning. So this is how a neuroma would look like in ultrasound. Okay, so how do you better appreciate the peripheral nerves? So you toggle the transducer and then you can follow it through wherever you would like to see. Okay, and then of course the normal fascicular architecture can vary depending on what type of nerve you're looking at. And then of course you can do back and forth scanning just to make sure that you're really looking at the nerve, that you're sure that that is a nerve. You have to check the veins, the arteries that surrounds it. You and also use tissue movement. This is very, very important because right now we're using also ultrasound to identify fascicles that happens in hereditary sensory diseases that are hereditary, like the ones that you see in, in, in very young patients, congenital problems. And then, of course, you can use Doppler when it is needed. So remember, to understand basic scanning and imaging techniques for a successful use of this modality and assessment of peripheral nerves and focal neuropathies. So you have to measure the nerve size, look at the internal architecture, do both a static and dynamic scanning, and then, of course, as I mentioned, also look for the surrounding tissue that could give you a clue as to whether you're dealing with a chronic problem or an acute nerve injury. Okay, so how does it apply for focal neuropathies? So this is helpful in the context of compression, trauma, post-surgical alterations, and tumors. So all of this can give rise to neuropathies. It can also provide some information about severity, can provide exact localization of traumatic or compression lesions, and also helpful in peripheral nerve blocks. So these ones are the usage of ultrasound when we're dealing with focal neuropathies. So here, the first nerve that we're looking at is the axillary nerve. We know that the axillary nerve is bounded by your humerus, and of course, superiorly we have your teres minor. Below that is your teres major, and then of course, we have the long of the triceps. And then this particular nerve can be both scanned posterior to the axilla, or you can even go anterior. So depending on how you would like to see them, you can both see them anterior and posterior. But what we're showing here with you with the scanning is the posterior approach. So the posterior, you put the probe at the quadrilateral space, and usually it is very easy to locate that because you just have to move your probe, scan it from superior down, and try to identify the muscles, especially the teres minor. And then when you see the teres minor, then you're sure that you're in the right spot. And then of course, sometimes you also see the other muscles like deltoids, and you can see the nerve that found right very close to the humeral bone. And so that is the quadrilateral space. Or if you want to see the anterior approach, you have to abduct your axilla and then put the probe vertical on the axillary space, and then you can look at the nerve both in the long axis and of course in the short axis. So here, this is actually a cadaveric view that Dr. J. Smith has studied, and you can see here that the axillary nerve is really very, very close to the humeral bone. Okay, and this is the way they're scanning it, and you can see all the other muscles, the teres major, the long of the triceps muscle that are around that area. So this is another way of scanning the axillary nerve anteriorly. Then if you would like to see the short axis view, same, you just have to move your probe 90 degrees, and then you can see already the short axis view of the axillary nerve, anterior approach, and then you can see all those nerves in that particular area. And in this case, we are looking at the axillary nerve. The other thing that you can use this is, of course, the posterior circumflex artery, which is very close to the axillary nerve. You can put your Doppler, and then also guide you in looking at the structures, and you will see them as shown here in this view. And then of course, this is another view, but as you can see, there is an abnormality on the right side. There is a swollen axillary nerve as compared with the one on the left side. So a side-to-side comparison is really very important, because sometimes what you might think to be real, just normal, is actually an abnormality. So just comparing the circumference, the cross-sectional area, we would be able to see the difference between what an abnormal nerve is versus that of the normal nerve. Then we go to your musculocutaneous nerve. Now you can also begin your scanning the musculocutaneous nerve at the axillary area. And what is shown here actually is if you abduct, just like what you did in the axilla, you abduct your shoulder and externally rotate it, then you will see that at the middle of that image is your axillary artery, the A there, and then you can see all the nerves surrounding that area. And usually the musculocutaneous nerve is towards the left. And then you can see there the biceps and of course the coracobrachialis, okay? And then the musculocutaneous is the one that is found in between those two muscles, okay? This is another scanning. So you can see here the ulnar nerve. You can also see the median nerve, but the musculocutaneous nerve is right below towards the left. So again, you can see the rest of the other muscles that surrounds it. And musculocutaneous nerve is very distinct. That's the only nerve there that is not close to the axillary artery. So you can kind of move it downwards and you can actually trace it down. Then here, this is how you can go through the scanning. So here, they approach the patient from the axilla and then they follow it through. And as you can see here, the musculocutaneous nerve will kind of position itself between the two heads of coracobrachialis muscle. And then as it inserts, you can scan it down, okay? So you follow it going downwards. And then you can see that the musculocutaneous nerve will actually inserts into the two heads of the coracobrachialis, okay? And then after that, it goes through the short head of the biceps and of course the coracobrachialis. So you're almost way to the distal third of the arm. And so you can see the nerve right there. And then as you go down farther, you can see that it could be now located between your biceps and your brachialis, which is very close now to the elbow. So here you can see that you can actually follow through all those steps in trying to scan this particular nerve and see the changes that happens as you go along. So when we evaluate the nerve, it is very important to be very systematic with how these nerves really looks like. Then of course, as you know, there is a distal branch of the musculocutaneous nerve. We have your lateral antebrachial cutaneous nerve. And usually, being the distal branch of this nerve, how do we try to scan them? So the first way or site to be able to see them is to look for the cephalic vein. Okay, the cephalic vein is usually located towards the lateral side, and this is a pure sensory branch of the musculocutaneous nerve. So the clue here is that you can see it because it is just beneath the cephalic vein. So once you see the cephalic vein, okay, then you will be able to see a hyperechoic structure, okay? Make sure that you don't miss that to be an enhancement of the image because of the hollow part made by the cephalic vein. But as you can see, it's very distinct. It's honeycomb pattern just beneath your cephalic vein. And so you can see it there. And you can also compare it. What we have here is the short axis view compared with the long axis view, and then how it looks like when it becomes abnormal. Usually this happens for those of you who are doing some procedures and is trying to get blood, peripheral blood on your elbow. Sometimes when you prick your patient to extract blood, you kind of go it through and through. You puncture the cephalosphere portion, not knowing that there is a nerve right there. And so this is usually the reason for the pain. And sometimes the patient would say, oh, that's so painful. It's only because you have actually hit the lateral antebrachial cutaneous nerve, which is just posterior to cephalopod. So just be very careful not to puncture that vein, because right beneath that is actually the lateral antebrachial cutaneous nerve. Now let's go to your ulnar nerve. As you can see, the ulnar nerve is also very important because it has some entrapment points that we need to consider. And as you can see, the more popular points for entrapment is at the cubital tunnel, at the medial elbow, and of course at the wrist. But let us see what else do we have here with regards to entrapment of ulnar nerve. Now, the first thing that I'm gonna show you here is that they found out actually what they call the arcade of Struthers. Now, of course, we are familiar with the ligament of Struthers, where it is the entrapment site also of the median nerve at the inner side of the arm, okay? But this one is the arcade of Struthers. So arcade of Struthers is not a common site for ulnar compression, but it could happen. This is made up of an aponeurotic band from the medial head of the triceps to the intermuscular septum, measured as 8 centimeters proximal to the medial epicondyle of the elbow. Okay, so 70% to 80% of the ulnar nerve pass under the arcade. So can you imagine, a lot of times we forget this nerve that could be compressed in this area, but it is always important to realize that a lot of times, 70 to 80%, the ulnar nerve also could be compressed in this arcade of Struthers. So it is measured to be 8 centimeters proximal to the medial elbow. So you can scan it back and forth and try to see how it looks like. So how does it look like? So here, this is a diagrammatic representation. And as you can see here, what used to be just a ligament, they actually identify that to be made up of what they call the internal brachial ligament or the brachial fascia. So as the ulnar nerve emerges, okay, from the area of the triceps, there is an internal brachial ligament. Okay, as you can see here, it's better to view it on the diagrammatic part so you will understand what are the structures all about. So the septum is right on top, and then there's a ligament on the medial side, and that is where the ulnar nerve emerges. And then it is possible that when you actually rotate your arm in pronation and supination, that nerve could be compressed, okay? And so that is the reason why this area is very important, because even if you treat the distal part and you don't treat this part here, it is possible that you can have an ulnar neuropathy that could be caused by this problem. So this is a very interesting findings that we see here. And so here, this is what they did. So they kind of release the septum and of course the brachial fascia as well. And then they expose the ulnar nerve. And as they expose the ulnar nerve, it actually releases that. So it is possible that if you have symptoms, because this is the area that could be compressed other than the one that we know in the cubital tunnel, it is very important to also scan this a lot of times, because this could just be the cause of what we are feeling to be causing problems in the elbow. So here, this is the cross-sectional area of the elbow. This is already at the cubital tunnel area. And so as we see here, it used to be that when there is any impingement of the ulnar nerve at the cubital tunnel, it could just be an asymptomatic type of subluxation like your leprosy or Hansen's disease. So this one, just like the median nerve in the carpal tunnel, has always been debated as to the normal value. Some people would say 7, some people would say 8. So it's always best to compare the right and the left. So here, if you compare right and left, you will notice that one side has a cross-sectional area of 14, while the other one is 8. And usually, it could be caused by so many things. It could be caused by the medial head of the triceps trying to also push that nerve out, or it could be just the epitrochlearis muscle that can also compress that. So there's just a lot of other causes that can cause it. Could just be a subluxation or a dislocation. So here, these are the areas that we need to see and scan and find out where the area of compression is. So we have to scan the ulnar nerve in both flexion and extension, because usually if we are suspecting for a dislocation or subluxation, usually the ulnar nerve is dislocated in flexion, but it goes back to normal extension. So that's why it is important that we kind of compare them and find out exactly where it's coming from. So you can see here the different levels. So let's say letter B level, it's just the entrance of the cubital tunnel. So you can see the nerve. It's covered by the Osborn retinaculum, as we say it. Okay, it's a piece of soft tissue structure that kind of prevent the ulnar nerve from going out. Okay, and then of course, as we move it downwards, then we can see the two heads of the flexor carpi ulnaris. And just on top of that, the one that you see with the triangular arrowheads is actually the arcuate ligament. The arcuate ligament is actually just the extension of the Osborn ligament. So the Osborn right on top, which prevents the ulna from dislocating or from subluxating, goes all the way down up to the two heads of the flexor carpi ulnaris. And then that is also where an impingement could happen, okay, between the two heads of the flexor carpi ulnaris. And then of course, you can go downwards furthermore, and then you can see a very distinct flexor carpi ulnaris. And then you can see also still part of the arcuate ligament. So this is characterized as the entire cubital tunnel. Some people would call the initial part with the Osborn as the cubital tunnel, but the proper cubital tunnel is referred to as the cubital tunnel where the arcuate ligament is between the two heads of the flexor carpi ulnaris. So that is what they term to be the proper cubital tunnel. Above it is not the proper, okay? Okay, so let's go to the different levels of the entrapment in the ulnar nerve in the cubital tunnel. So level 1 happens at the epitrochlear groove. And so there is an osteofibrous ring that are formed by the medial epicondyle, the olecranon. So when you scan it, you actually put your probe on the illustration. One part of the probe is on the olecranon process. The other one is on the medial epicondyle. And the one that you see in the middle is actually the ulnar nerve. And then beside the ulnar nerve, sometimes you can see the medial head of the triceps as well. So you do a dynamic imaging. So you flex and extend the elbow to assess for number 1, triceps medial head compression. If there is a compression that is already happening with the triceps, then number 2, there could be an ulnar nerve instability. In other words, the ulnar nerve kind of move out from the groove, or in some instances, there are 2 snaps. The first snap is the ulnar nerve. The second snap is the medial triceps. So we call that the snapping triceps syndrome. So this is the purpose why you need to do a dynamic imaging. So you will see all these 3 if it is present. Not everything will be present, of course. You will be able to see them. Okay? And then, of course, you can also see here that when you do extension, the the ulnar nerve is within the groove, okay? But as you flex it, it goes out of the groove. So they characterize this as subluxated. Some would like to characterize this as a child's type A, and it is present in about 37% of patients. 91.4% are bilateral, 21% will show neuritis. So a lot of times it could just be asymptomatic. So you don't need to worry unless you're actually having some problems there. The other one is what they call the child's type B. This one is actually a dislocated ulnar nerve. So a subluxated is not totally dislocated yet, but a dislocated ulnar nerve is the one that is actually out of the medial epicondyle when you flex it. And this is present in about 20% of healthy individuals. The reason for this is it could be due to the hypoplasia or absence of a cubital tunnel, retinaculum, or Osborn ligament. Some people might not have that Osborn at all, or it could be a very shallow cubital tunnel. So there's just a lot of cause. So depending on what findings you can actually see with a patient. Then of course, you also check for ulnar nerve instability. Of course, as we have mentioned earlier, the Osborn retinaculum is the one that keeps the ulnar nerve inside, okay? But sometimes when there is unstable ulnar nerve, it could be displaced out, and it is prevalent in asymptomatic elbows with 56% showing an abnormal cross-sectional area. So it's possible that you don't feel anything, but actually, if you measure the cross-sectional area of your ulnar nerve, it could be swollen due to the fact that your ulnar nerve is actually subluxating or to some extent dislocating. Next is, of course, the snapping tricep syndrome. We know that there should only be one snap. And the first snap is usually made by the ulnar nerve, okay? While the medial distal head dislocates over the medial epicondyle, that would be the second snap. First snap, ulnar nerve, second snap, the medial triceps. Okay, the cause is unknown, but if you are doing ultrasound, the dynamic ultrasound imaging can diagnose this condition, and this is present also in patients with asymptomatic elbow problem. Both the ulnar nerve followed by the medial head, the triceps dislocate at the medial epicondyle. So you can see here 2 snaps when you move it. Then of course, we have the level 2. This is at the proper cubital tunnel. So this is what we were talking about. The one above is just the covering of the Osborn retinaculum, but just below that, we have a ligament called the arcuate ligament that binds the 2 flexor carpi ulnar heads, okay? So there are 2 heads on both sides. Then there is a ligament that bridges them. The ulnar nerve is in between. So ulnar nerve enters between this area, and this is also where they say to be the more common site of impingement in the ulnar nerve. So they call this the proper cubital tunnel. So remember that this is the level of the proper cubital tunnel. And of course, there is a diffuse flattening of the ulnar nerve with proximal swelling at the level of compression. So as you can see here, for example, in this slide, you can see in long axis view that one side is swollen, then towards the distal area, it becomes smaller. So that is to be characterized as notching sign. There's a hypoechoic swelling at the level of compression. Then of course, from level 1, we go to level 2, then of course at the exit part, which is the level 3. It is also possible that there could be compression of the ulnar nerve right where the nerve exits at the flexor carpi ulnaris tendon at its 2 heads. Now we go to the ulnar nerve at the hand. Of course, this is also very interesting because if you look at the nerve passes through another tunnel different from the carpal tunnel. And this is formed by the pisohamate ligament. And as you can see, the nerve, as it runs distally, it moves also and curves distally towards the thinner eminence of the thumb. So as you can see here, this is a very important nerve, because if you actually impinge that, you can affect also the grip of your hand, and there could be some consequence in the hand as you compress that part of the ulnar nerve. So here, this is actually made as a result of analyzing the cyclists. A lot of times we are dealing with the cyclists, and for those of you who are also doing some biking, you have to be very careful, because as you can see, there are so many ways you can actually compress that particular nerve, depending on the type. It could be very proximal, the type 1, in which case there could be a mixed motor and sensory. So there could be weakness together with a sensory deficit. In type 2, it is just pure sensory. In type 3, it could just be pure motor neuropathy. In type 4, it could be a pure motor neuropathy, but with sparing of the hypothenars. So the hypothenars are no longer affected. And in type 5, it is a distal motor neuropathy. Okay, so depending on which area is affected, then we can actually diagnose and pinpoint exactly where the nerve lesions is. So this is becoming very interesting. So here, for example, this is the position of the probe. So the reference actually is your flexor digiti minimi. From the point of your pisiform, you go farther distally, and as you move distally, you can see the muscle, okay? And the muscle is just right on top of the hook of the hamate. So the bony acoustic landmark that you see there that is curved is the hook of the hamate, and right on top of the hook of the hamate is the flexor digiti minimi. And the flexor digiti minimi is the one that divides the sensory part of the ulnar nerve, which is superior, and the one that is underneath that, which is your motor, that is your deep branch of the ulnar nerve. So if you have some difficulty in trying to differentiate motor and sensory, all you have to do is to go a little forward, look for the hook of the hamate, and then once you see it, the muscle right on top of that is your flexor digiti minimi, and then the nerve on top of that is your sensory branch. The muscle, the nerve that is below that is your deep branch of the ulnar nerve. So very easy to scan. So here, as you can see, the deep branch of the ulnar nerve was identified in cadaver, and it is very interesting that this particular nerve also is identified a little distal from the hook of the hamate. You have to see the hook of the hamate first, and then as you move forward, okay, you can see it just beneath your flexor digiti minimi. Okay, so that is how to identify those two nerves. So what is the significance of the deep branch of the ulnar nerve? This is sometimes called the Guyon Canal type 2 syndrome. Okay, this is seen among bikers, jackhammers, or maybe just an anatomical variance. And this is what they consider to be the cyclist's palsy. And the cause is, of course, as you know, when you do your bike, you really have to grasp tightly, and there is a hyperextension. So the smaller the grip is, the higher the amount of grip that you will have to apply. That's why for some cyclists, what they do is they actually increase the grip size of the bike in order that they will not be gripping it too much, because the smaller it becomes, you have a tendency to grasp it more and to hyperextend it more, causing this kind of problem. Okay, so when you do this, you can develop this kind of problem of deep branch of the ulnar nerve neuropathy. Okay, so here, this is another representation of how to look at it. Uh, as I mentioned earlier, the deep branch is motor, but the one that is above it is the superficial branch. That is also very interesting because this superficial branch is supposed to just be a sensory branch. But there is a motor side of the superficial branch of ulnar nerve that goes to the palmaris brevis muscle. So the palmaris brevis muscle is innervated by superficial branch of the ulnar nerve, which is actually the sensory branch also of the other fifth and one half of the fourth of the fingers. So it's very interesting that this type of nerves could be sensory, but then there is a motor branch that is distal to that. And so as you can see here, there is a hypoechoic. When you try to scan it, you can do dynamic maneuver. First at rest, okay? So you can see the palmaris brevis wavy, but as you try to contract it, then you contract it by actually moving your fifth finger out and in, out and in. You can see that muscle contracting, and you can see that the muscle that works there is actually your palmaris brevis, okay? So when we do ulnar nerve, also since we're doing both EMG and ultrasound, you have to realize that there are other things that could cause symptoms. It could be an ulnar neuropathy from multiple locations. It could be a C8 radiculopathy. It could be a thoracic outlet compression. It could be a brachial plexopathy involving the lower trunk and the medial cord. It could be part of the carpal tunnel syndrome. So these are just the differential diagnosis. Now let's go to the radial nerve. So the radial nerve is also very interesting because there are a lot of compression sites. We will not enumerate all of them, but we will just mention a few of the compression sites, the most common one that are compressed. So here, this is at the humeral groove. So if you are going on a drinking spray, maybe, and then you accidentally slept on your arm, then suddenly you have difficulty making a grasp. You have sensory deficit right in the dorsal side of your wrist and forearm, and you are developing actually a radial neuropathy because of the impingement at the spiral groove of this particular nerve, the radial nerve. So you can see here in this scan that we have a narrowing, there is a notching of that radial nerve, and then it is actually very close to the bone, at the humeral bone, and so you can easily identify it. And this one is most commonly associated with traumatic nerve lesions, usually in long bone fractures. Or it could be due to the traction effect during mobility with restriction because of the intermuscular septum. And then, of course, if there is a bone fracture, there is also an associated nerve swelling. So it's very important that if we have fracture of the humerus, you better check your radial nerve just to ensure that it's not affected, because it's really just very close to the bone. So the next one after that would be at the leash of Henry. Now, when you scan the radial nerve right at the elbow area, okay, you actually put the probe very close to the lateral side, okay, and as you move it back and forth, back and forth, back and forth, you kind of see the supinator muscle. So when you move a little proximal to that, in your collateral artery, we call the deep branch, we call the arterial branches of the recurrent branch of the radial artery is located. So this radial recurrent artery, as it pulsates, okay, this could cause compression on the radial nerve that is located above it. So they call that site the leash of Henry. Okay, this is a collateral artery that is in contact with the deep branch of the radial nerve just before the arcade of Frost. So before you go into the supinator muscle, the area where the deep branch of the radial nerve goes in, okay, we call that the arcade of Frost, and you can move proximally, then look for the nerve right there at the leash of Henry, and this is exactly the site where that is located. And then of course, as we go forward, then you can see here the zone 2 entrapment site. This is the most common site. This is the arcade of Frost. This is the superficial layer of the supinator muscle that forms a band right there. And then that is where the radial nerve goes in. The moment the radial nerve goes in, it becomes the posterior interosseous nerve. Whereas the other branch, the superficial branch, is just above it, and it goes all the way to the distal part of the forearm, the superficial branch. But this one, the arcade of Frost, the deep branch, is a pure motor branch of the radial nerve. So if there is any impingement on that side, then of course we can say that there is a lot of weakness on that particular muscle innervated by those nerve. The deep branch of the radial nerve. While if it is just a superficial branch, it's a pure sensory, and there's really nothing to worry about weakness there, except that you feel a lot of numbness on that side of your forearm. Then of course, we're saying that this could be caused by a chronic repetition motion of pronation and supination. Okay, so you can measure it. It's 1 centimeter distal to the leading edge of extensor carpi radialis brevis. And then of course, you can see it. It goes into the 2 layers, in between the 2 layers of the supinator muscle. You can move it back and forth to be able to see that branch of the supinator muscle. So here, you can see both the branch of the radial nerve and the hypoechoic swollen branch of the deep branch of the radial nerve that is actually compressed in this slide here. So the zone 3 is what we call the intratunnel compression of the radial nerve. So when there is compression on the side, it is usually due to masses, lesions, or fibrous bands. This is a fixation point. So in other words, if there is any tightening on this area that could be due to some sports or some activity, this area is the one that is to be involved. So you can see here in this slide, for example, a very swollen radial nerve, okay, in between the layers of the superficial and the deep supinator muscle. Then of course, as the deep branch of the radial nerve exits, it gives off a recurrent branch to the extensor digitorum communis. So as it exits, one branch goes to the EDC, and the rest of the forearm, it goes to the extensor muscles of the wrist and the hand. And by the way, even if we say that this posterior interosseous nerve is motor by majority of the time, there is a sensory fibers that it carries that innervates the carpal ligaments and joints. So can you imagine if there is any pain in the ligaments and joints at the dorsal area, it could actually be coming from the deep branch of the radial nerve. This is a motor branch of the radial nerve, and this fibers goes all the way to the dorsal portion of the wrist. Okay, so you can also scan that part to be able to see the branch of the posterior interosseous nerve. Then of course, how do you do this? How do you actually scan them? If you're doing proximal to distal, you have to do the probe from anterior to posterior while you are pronating the forearm, so that you can see the entire nerve as you move along. If you're moving from distal to proximal, then you have to move it from posterior to anterior while you are supinating the forearm. This way, it would be easy for you to see the short axis of the nerve as it moves back and forth, as it passes through that arcade of Frost and as it exits. So this is one way that you can actually facilitate the scanning of the nerve. Then of course, We have another condition. This is the distal branch of the superficial radial sensory of the radial nerve, and it could be also compressed at the level of the wrist. And this sometimes called is the Wattenberg syndrome or the chiralgia paresthetica. Those patients who were handcuffed, for example, they can compress this nerve and it could cause problems. So how do you scan this? Usually you can scan it, you can start from the elbow, trace the superficial sensory, you follow the brachioradialis because that is where it accompanies all the way to the site of the first dorsal compartment. And so sometimes you mistake, or this could be a differential diagnosis for de Quervain syndrome or the intersection syndrome, because they almost have the same symptoms. Of course, the sensory would have some deficit, sensory deficit, and the de Quervain's is just plainly pain. But how do we actually locate the area? So it's about 8 centimeters proximal to the tip of the distal styloid process. So this is where that nerve becomes superficial. So when you scan them, make sure you're using a very nice probe because you might be able to see that very tiny nerve right on top of that could be compressed at the wrist, okay, causing that pain that we sometimes have a hard time differentiating. Are we dealing with a de Quervain's versus an intersection versus a chiralgia paresthetica? Then let's go to the median nerve. The median nerve is a very common, popular nerve because this is where we see a lot of carpal tunnel, of course. Okay, so let's see. So here, the pronator teres. The pronator teres is actually a problem in the nerve, which is actually lateral to the brachial artery in the medial upper arm, or if it is above the elbow, the median nerve courses between the biceps brachii and brachialis, or if it is at the elbow, it could be between the ulnar and humeral heads of the pronator teres. So this is where the compression happens, and usually the symptoms of the pronator teres syndrome is almost similar to that of the carpal tunnel syndrome. The same, almost the same. So that is why the lesson that I've learned here is that when you are thinking about the carpal tunnel syndrome, don't forget to also scan the pronator teres side. So you will see whether there are findings that you actually see in that area when you scan it, okay? So after that, when the median nerve enters into the pronator teres, then it becomes an interior interosseous nerve, okay? So the anterior interosseous nerve could be scanned in different areas. You can actually follow that as you actually move the median nerve from the pronator teres down up to the distal third of the forearm, then you can see the different patterns of the anterior interosseous nerve. But what is very significant here is that when we are dealing with anterior interosseous nerve, as I mentioned earlier, it is very important to compare the right and the left, whether one area is swollen over the other. As you can see here, one area is swollen, the other one is normal. Then also compare the longitudinal view, whether there is notching in the nerve. There is hypoechoic swelling at the proximal part. But also, if you're not sure exactly when it starts, then you can also check for the other structures. And in this case, you would like to check the pronator quadratus because this is one of the muscles that is innervated by the anterior interosseous nerve. And if it has been chronic, then you will notice that there is a denervation, fatty infiltration that you see in the quadratus, in the pronator quadratus as a result of the abnormality in the anterior interosseous nerve. So the anterior interosseous nerve originates at the level of the pronator teres, and it all the way moves to the anterior interosseous membrane. It is a motor nerve that innervates not only the pronator quadratus, but also the flexor pollicis longus and the second, third flexor digitorum longus. So that is why when you try to check the anterior interosseous nerve, you can ask the patient to make an O sign, and an ability to make, to resist that means that your anterior tereos nerve might be affected, okay? So that is an ability to oppose the first and second digits. So you also have to check, as mentioned earlier, an isolated atrophy and fatty infiltration of the pronator quadratus. Then, of course, we look at also the median nerve at the level between the palmaris longus and flexor carpi radialis. So this area could also be an area where you can also compress the median nerve. This is still prior to the carpal tunnel itself. This is 5 centimeter proximal to the wrist, and this courses ulnar to the flexor carpi radialis, or the FCR, or radial side of the median nerve. So as you can see on the first slides here, you will notice that it is actually between the flexor carpi radialis, because tendon of the palmaris longus would not always be present all the time, but it could also be seen between the median nerve and the flexor carpi radialis. And it could swell, and since it is a sensory branch innervating the mid-proximal palm and thenar areas, that area could also be affected. So this particular nerve, this is actually the palmar branch that could go all the way to the thenar and, of course, the middle part of the wrist. Now, this is also very important because sometimes for those patients who undergoes surgery, and in spite of the fact that according to the surgeon, they have released the flexor retinaculum totally, there is a persistence of hyperesthesia or sensory loss. Then you have to check this nerve, because probably they might have accidentally hit that nerve, and that is the reason why it has also compressed this area on that site, because this nerve doesn't go into the carpal tunnel, but this is above the carpal tunnel prior to the nerve going into the tunnel. Okay, so let's go to the carpal tunnel. So as you can see, there is a proximal layer, there is a distal layer of the carpal tunnel. So the proximal is made up of the scaphoid and pisiform, and then of course the hamate and the trapezoid. Then of course there is a bridge that makes up the flexor retinaculum. So as you can see here, on the proximal part, the flexor retinaculum is very distinct, and the median nerve is just right underneath that. And you can see all the tendons below that, the flexor tendons of the wrist. Then as you go and move distally, then you can also see the median nerve becoming smaller, but at the same time, you can still see the flexor retinaculum right on top of that, very distinct. It's echogenic, okay? And then you can also compare the long axis view and try to see if there is notching or narrowing of that median nerve as you. For carpal tunnel syndrome findings, the common way of doing it is either to do a tracing, or you can do ellipse, okay? A lot of times you say that ellipse could be reproducible. So if you are a beginner, then you can always get the same findings as the one that has been doing it for such a long time. But usually you will notice that the nerve is either very swollen, or there is a flattening. And then if you look at the long axis view, there is a notching. So there is a proximal hypoechoic swelling, and on the distal part, there is notching and it becomes more narrow. So we measure from the inner border of the epineural. Okay, it's very distinct, okay, and then you can get the measurement. Usually they're saying it's 10 to 12 as the normal, okay, but it is always important to compare it right and left, okay. Now, what they see to be a very reliable way also of measuring is that you have to compare the reading from the pronator quadratus and that of the measurement at the carpal tunnel inlet. And a difference of 2 millimeters square means that you have a carpal tunnel, regardless of whether the size is more than 10 or whether the size is maybe less than 10. but this one is a very good way of finding out whether there is already a compression. The sensitivity is 99%, and of course, specificity is 100%. So you can always rely on these findings to be a very reliable test for diagnosing carpal tunnel syndrome. The other thing that you would like to see is, of course, the hypervascularity. If you turn on the power Doppler, you can see a hypervascularity that could also indicate a pathologic finding that something is wrong with the nerve. So always don't forget to do the power Doppler evaluation. Now, for some of you, you may be seeing patients who have been operated already, and then you would like to see whether they have completely done the job well. So here is what you can see, and you can also scan it by yourself. So you have to get a measurement from the proximal carpal and also from the distal carpal. Now, as you can see here, it looks like there is a failed retinacular release because of the fact that you can still see the retinaculum there. So even if they say maybe that they have actually released it, they may not have completely released the flexor retinaculum. And that is why there was a failed surgery. If you move it going to the distal site, you can see a hypertrophic scar, okay? And that is where probably they inserted the knife. And you will also notice that there is a very thick hypertrophic retinaculum. So they have not also completely released the retinaculum. And that is the reason why the patient continued to feel or experience all these signs and symptoms of the carpal tunnel. So for prognosis, an increase in the CSA reading in ultrasound, which means worse carpal tunnel, do not necessarily correlate with better outcomes. Because as we try to scan, we might be able to see a very swollen nerve. And so after the procedure, we might expect that maybe this will turn out to have a very good outcome. But according to studies, it doesn't correlate. And as I mentioned earlier, a difference of 2 millimeter reading is very reliable. And of course, avoid too much magnification because sometimes there are secondary causes of carpal tunnel. And one of them could be a ganglion cyst, which is underneath the carpal tunnel, or the median nerve, I should say, or there could be a swelling of the flexor tendons, tenosynovitis, that could compress the median nerve, causing the carpal tunnel. So it's always important to avoid too much magnification. Look at the floor of the carpal tunnel because you might see some pathology there. Of course, always check the flexor retinaculum for persistent pain after a surgical release. And of course, the last part, we're almost done. This is, of course, the million-dollar nerve, okay? The thenar motor branch of the median nerve. Of course, the median nerve will go distally, and as it goes distally, the nerve, that nerve which is made up of motor nerve, will go back and innervate the thenar motor areas, the thenar muscle of the motor areas. And sometimes this nerve will also be severed if the surgeon isn't aware actually where they are located. If they go very laterally or towards the thenar area, they might really severe this nerve. And this is the reason why there's a lot of claims, because once you hit this nerve, it will completely paralyze the thenar muscles. And you know that in the hand, the most important function is the thumb. If you lose the thumb, then that would actually paralyze a lot of your function in the fingers. So it is very important that we know exactly where this is, and be careful that if there are surgeons who would do this, that we will have to guide them to orient them where exactly it is, so that this could be avoided when there is a procedure. So thank you very much. I know I have taken a lot of your time, This is really a very long lecture. Okay, so I hope you learned something tonight. Thank you.
Okay, I'm really exciting for this amazing talk. As usual, dear Professor, yeah, well, dear Professor Jem.
Yes.
Also, I think Professor Jeffrey is joining us also. I want to welcome him also. All the attendees, please, for any questions, you must to put it in Q&A buttons, please. First, I want to ask you, I think, two short questions. First, what about the timing to proper scanning for the nerve pathology? So I mean, in electrodiagnosis, we can take in my considerations 4, 7, 10. 4 days, 7 days, 10 days. 4 days for any abnormalities of the median nerve, motor nerves. 7 days if any abnormalities of the sensory fibers. The 10 days if any abnormalities of the muscles. So it is considered to be put in mind in ultrasonography, or differ a lot?
Yeah, I think Dr. Jeff, are you here?
Yeah, I think Dr. Jeff. Yeah.
Okay, so usually we see patients coming to us from different stages of the disease, and sometimes when we see them, they might have gone to some other doctors, they might have seen already other consults, and then they might have done some procedures. So to me, personally, when I see patients with with carpal tunnel, for example, this is the most common that we see a lot of times. I would always repeat the ultrasound a week after just to see what is the status. And then, of course, since I usually put them on a physical therapy program, then I would like to know if there's any change or if there's any other improvement that the patient feels. And as mentioned in the study here, that a bigger cross-sectional area doesn't always give a very dramatic results after a treatment, and in this case referring to carpal tunnel release. So actually I was expecting, if you have a very big cross-sectional area, it's very swollen, then after the release then you will have a very good outcome. But it seems to me that the study by the DBUN and colleagues, it was just released this year, show that there's really no better outcomes after that release. So maybe we have to take patients one piece at a time, or maybe we have to approach them from an individual point of view, not really comparing it with other patients, because they might have different. I don't know what Dr. Jeff would have in mind if he is around.
If I can get him to access if you want. Just okay. My second question still, I will join Dr. Jeff. In neurotemesis, the two end stumps, it's retracted. So how can we measure the distance between the two stumps to help the surgeon, if it is filled or not?
Usually, I would go. I would suggest there's a procedure right now. They call it Sonics procedure, where they do an ultrasound guided release of the flexor retinaculum laparoscopically. So there is a distance that they measure it from the middle. They put a line at the midline of the middle finger, and they actually move it towards the ulnar side just to avoid the thenar motor branch. The procedure is called Sonex. And that procedure ensures that you don't hit the tenomotor branch, but at the same time, you completely release the flexor retinaculum. So these are new ways of treating carpal tunnel. Although if you are doing the open type, I really don't know how the surgeon would be able to ensure that it is completely released. So I have no idea, but I mean for a hand surgeon, they should be able to release everything.
Yeah.
Yeah.
Okay. I think Dr. Jeffrey need to share us an audio, but I don't find him. Okay. Dr. Jeff?
Oh, there we go.
Yeah, how are you?
Hi, Dr. Jeff.
Hi. Sorry,
Why
I've been trying to figure out
why
how to
did
unmute myself.
so hard for me. You're here.
It was a great lecture, Dr. Jim.
You should be the one to be lecturing this.
Okay. Well,
Yeah. Where are you, Dr. Jeff? We can now join us also with your video. Okay, Dr. Jeff. Yeah. Okay. Dr. Jeff? Where are you?
there we go. I've been muted. That's why.
Yeah.
Okay. When I hit video, it muted me. You want me to try the video again?
I think you can right now.
Okay.
Yeah.
Anyway, what was there a question for me? I'm sorry.
Yeah, well, I ask what about in neuropraxia, the timing that it's proper to scan ultrasonography. This is equal to the electrodiagnostic perspectives, as I mentioned, Professor Kibura, Professor Mabathi, and also he mentioned that after 4 days, the first 4 days of the injury, we can detect the abnormality in motor fibers. But after 7 days, we can detect any abnormalities of the sensory fibers, and 10 days for the muscles. It is parameters or this time equivalent in ultrasound finds. We can see what about the echogenicity, the Doppler finds, the cross-sectional area, or need to be long beyond the electrodiagnosis. So
Okay. No, that's a great question. I get asked that a lot. So for me, when I'm going to time the exam, and that includes electrophysiology or with the anatomy with ultrasound, I want to know what question I'm going to answer. So for example, if in a case of a trauma and maybe there's multi-trauma, I may want to find out where the injury site is. I can find some of the features of the trauma right away.
yeah.
And so I can do that immediately. With most things with nerves, some of the features of wall area degeneration won't take place until, anywhere from, 4 to even 21 days if it's a mild partial injury. So I have to consider, why do I want to image it? Am I trying to localize it, or am I trying to see how severe it is? And we will even do electrophysiology in the trauma situation if we're just trying to localize things and also determine maybe if it's complex enough, just by using motor unit recruitment, can we tell is there a central process or a peripheral process? And sometimes we can't even tell that in multi-trauma. So that'll help us. But for precise localization with electrophysiology, and certainly for severity, you know, we want to consider that it takes virtually 9 to 11 days before you start seeing a large factor of ulnar degeneration. So the same factor, if we're looking at severity of a neuropathy with ultrasound, one of the things that we're going to do is look at muscle echotexture, and that's going to take a similar amount of time that electrophysiology will, and sometimes up to 2 weeks or so before we start seeing any kind of change in atrophy and fatty infiltration, things like that. We can see swelling of the nerve roughly for a neuropraxic injury, like you mentioned. I know I'm circling around your question, but we can see swelling of the nerve, you know, within generally 48 to 48 hours to 4 days or so. And when you start seeing that response, so generally, if you're just looking for a partial injury or a neuropraxic injury for localization, we want to wait a few days, but usually within about a 5-day window, you should be able to see things a little faster than electrophysiology. That was long-winded, but that's it's kind of complex answer.
Sure. Yeah, great. Thanks, dear Professor Jeff. Okay, any questions for the attendees, please? We have Professor Jeff and Professor Jam. Please, any questions? Okay, in severe axonotmesis and little bit how to differentiate between the partial loss of the nerve or complete. As you know, in electrophysiology, it's a little bit difficult or hard to differentiate either after 4 or 6 months to be axonotmesis or neurotmesis. So we cut edge this with the sonography. You hear me? Hello?
Yes. You're asking Dr. Jeff?
Yeah, asking.
Oh, I'm sorry. I thought that was to Dr. Jim.
Okay.
Okay, sorry about that.
So, okay.
Dr. Jeff,
right,
go ahead.
I'll go ahead. So this is one where electrophysiology and ultrasound really go well together because they have strengths and weaknesses, and Dr. Jim pointed some of those out in the early slides. So the single best modality we have for distinguishing neuropraxia and axonotmesis is electrophysiology. If we are able to stimulate and record on both sides of the lesion, then we can distinguish in very precise terms how much is neuropraxic and how much is axonal based on the distal sensory nerve action potentials and the distal compound muscle action potentials. So electrophysiology is the best for that. Ultrasound has some capabilities, and what we're learning as we start studying the internal fascicles of the nerve, as we start, when you see axonal injury, you'll see damage and changes within the fascicles. And Dr. Jim pointed out those get enlarged somewhat and coalesce a little bit as they're damaged with conventional ultrasound. As we start using this ultra high frequency transducers, when we're getting up of 48 and 70 megahertz, we can actually see that they become almost fibrotic looking in these chronic axonal conditions. And you can even see components of it. If I had my computer ready, I could show some slides of that. But so we're doing a lot of work with that. So it does have a lot of capabilities too that help us. And what's nicer about ultrasound when you add that in is you can see the precision of the injury in much better detail than you can with electrophysiology. So electrophysiology will qualify the relative severity of the axonal loss, whereas the real precise nature of how it was injured and where it was injured and what components of the nerve are injured are shown by ultrasound. And as you already alluded to, if you have a complete neurotmesis where there's a loss of connective tissue, that will look exactly the same electrophysiology as a complete axonotmesis. So that's where ultrasound is very strong, because we can distinguish whether there's any any continuity of the connective tissue. And in that situation, we know it's not going to get better without surgical intervention or some kind of intervention on our part. So they work very well together, and the weaknesses of one are sort of covered by the other. So that's why we always recommend doing them both in a trauma situation.
Okay. At the end, I want to thank dear friend, Dr. Jim, about this very, very, very interactive and informative lecture, as usual. So I hope this not the last one. And also, dear Professor Jeffrey, I hope to suit your time to share us in webinar soon. Thanks a lot for the attendees, and good night and good afternoon here in Egypt.
Dr.
Okay.
Jeff.
Yeah.
I miss you, Dr. Jeff.
Thank you.
I miss you too, Dr. Jim, and your chapter's coming your way soon. In fact, it's done today. I'm going to talk to you about sending it to you.
I thought you were in Egypt.
Yeah. Soon after this crisis end, I will do a conference, a big conference. Dr. Jeffrey and Dr. Jim, sure to be one of the eminent talkers. Yeah, and a lot of tourists. Yeah,
That would be great.
Thank you.
I want to ride a camel.
Okay. Thank you, dear. Okay, bye.
Thank you, Dr. Jeff.
Bye.
Bye now.
Okay, bye.
Good night, everybody.
Okay.
Night, everybody. Thank you.
Bye.